Hi, this is David Sandhu. I am one of the endovascular and interventional neurology and stroke physicians at Sanford Sioux Falls, and we'll go into about a 35-minute presentation about stroke, both ischemic and hemorrhagic. We'll start with some definitions, the first definition being that of stroke. Traditionally, stroke used to be defined as a clinical syndrome of quick onset of focal deficits which last at least 24 hours. This focal deficit business means that the pattern of problems that a person has that follows um, defined patterns based on the neuroanatomy of a person and of their brain. Now, this definition has been supplanted by an imaging-based definition, which basically says any of these clinical syndromes of focal deficits which have positive CT or MRI imaging. Transient ischemic attacks are basically very similar to strokes, though main difference being that one, they reverse completely, and more importantly, now that MRIs and CTs are available widely, that they do not have any clinical and any imaging changes that would correspond with the clinical changes that a person experienced, which led to the suspicion of stroke versus TIA. Going into a brief slide about epidemiology because this is important. This stroke is the fourth most common cause of death in the U.S. and it leads to 130 to 140,000 deaths a year. And there's 750,000 new strokes a year, and this accounts for about a total of $35 billion in direct and indirect costs. Risk factors. You basically divide these into two, the fixed and the modifiable. The fixed ones are listed. The modifiable ones are the more important ones because those are the ones that lifestyle and appropriate medical interventions can optimize and therefore reduce the risk of a person having a stroke to begin with. And this is, I think, equally important, if not even more important, than the treatment of strokes because once you get to the treatment, a lot of the damage and the problems have already arisen. And we as a healthcare society pay not enough emphasis on preventing disease and pay an overwhelming amount of emphasis and importance to treating disease. Then getting on to the types of strokes. Two main types the hemorrhagic stroke, which is basically bleeding either within or on the surface of the brain, and then ischemic stroke, which is basically blockage of a blood vessel, large or small, for long enough that permanent damage to brain tissue sets. Ischemic stroke is almost 90% of all of the stroke that we see. The general pathway, the general pathology that these follow, the ischemic strokes follow, is that a blood vessel gets blocked. It causes ischemia, which is tissue damage because of lack of oxygen, which eventually ends up into tissue death because of a cascade of events that we won't go into. Two main types. One is the thrombotic strokes, which basically means that the cause of the stroke developed at the site of the stroke itself. Embolic strokes, which basically means that the cause of the stroke, the blood clot, is what I mean by the cause of the stroke, that developed elsewhere in the circulation, maybe the heart, maybe the aorta, maybe the carotid arteries, maybe in the leg, and then traveled until it caused the vessel occlusion that we had just mentioned. These are the different types of thrombotic and embolic strokes that we see. We won't go into too much detail about these, but they're listed for your review. This is a good image, a good diagrammatic depiction of all of the things that were mentioned in the previous slide. So briefly, starting from the heart. You can have atrial fibrillation, because of which left atrium develops clots very often in the left atrial appendage, which is not depicted here. These clots then, with cardiac cycle, get pumped into the left ventricle, get ejected into the aorta, and then can find their way up. You can also have ventricular thrombi because of large MIs, infectious disease, hypercoagulable diseases, and also and also aortic arch thrombi if a person has bad atherosclerosis or has had aortic trauma in the past and dissections. Thrombi can develop here. Similar problem can occur because of crowded bifurcation plaques, which not only reduce the volume of blood that's being supplied, but also, more importantly, can be the sources of cholesterol, fibrin, plaques, which can break off and cause occlusions upstream, which basically is what this site is showing. Then you can have same type of problem develop in the large vessels at the base of the brain. And then finally, you can have these tiny small blood vessels called the penetrating arteries, which basically suffer atherosclerosis, enabling strokes. This is basically what we talked about in the previous slide. This core versus penumbra discussion is extremely important, and we'll come back to it in a clinical case that I will go over towards the end. But the one thing that I want all of you to take away from this slide is that the core, which is the established and therefore completed stroke, is the one that you will not be able to reverse. In this particular depiction, this is the volume of the core. Penumbra, or ischemic area, that is all of this adjacent and surrounding tissue, which is at risk of converting into permanently damaged tissue, but not yet is permanently damaged. And the length of time which this takes to convert into this is dependent on a host of factors, and therefore is variable. However, the sooner you, if possible, um, restore blood flow to this part, the less chances that the actual infarcted core, the actual dead tissue, will expand. And that is universal. Um, then a quick slide about the hemorrhagic stroke. As I had alluded to earlier, depending on the location of the bleed can be intracerebral, which means that it is within the tissue of the brain, or it can be subarachnoid, which means that it is on the surface of the brain. You can also have subdural hemorrhages, which are basically between this layer, which is the dura mater, and the skull. And again, all of those have different etiologies. All of them have different predisposing factors, and also different outcomes depending on the location and the size of the bleed that has occurred. In general, bleeds have a higher mortality rate when compared to ischemic strokes of the same size. Then going on to the risk factors for hemorrhage, again, we won't go into detail about these, but they're listed for your review. Subarachnoid hemorrhages, two main types. One are the aneurysmal subarachnoid hemorrhages, and the second ones are the traumatic subarachnoid hemorrhages, which form part of the big overall category of TBI. Getting into the clinical is important. We will generally broadly divide strokes as the large versus the small vessel strokes. Large vessel strokes have gained more important ever since most of the recent trials of mechanical thrombectomy were positive, starting from the 2015 October all the way up to now. Um, Basically, large vessels are blood vessels that include the carotid arteries, the anterior cerebral artery, the middle cerebral artery, the posterior cerebral artery, the vertebral artery, and the basilar arteries. These are vessels in which you can safely place a catheter and a clot retrieval device, and therefore can restore blood flow. Again, depending on a host of factors. And small vessels are vessels in which you cannot do these things. The only interventional options that are available for small vessel diseases are intravenous TPA. After which it is all risk factor management, then secondary prevention and minimizing complications. Therein the importance of distinction between the small and the large. Are the um, common presenting symptoms of a stroke? um, Weakness of the opposite side of the body, inability to understand language or produce language, field defects. You have one half of the vision missing. For instance, if you have a left-sided stroke, you'll have trouble seeing objects on the right side of the body, and vice versa. You have gaze deviation to the side opposite to the occlusion. Um, then you have neglect, which is an important, very important concept, because think of it as you standing on the left side of a person, and no matter which sense you stimulate, be it verbal or be it auditory stimulation, physical stimulation, or visual stimulation, the person does not pay attention to stimuli on the left side of the body. They will keep looking to the right side to see where the source of the sound is, where the source of the touch is, and where the vision is. This is an indicator of a large right-sided stroke developing, the same way that loss of the ability to communicate verbally, garbled speech, is an indicator of a large left-sided stroke happening. This is an important concept. Agnosia: a person does not admit to or recognize even that they have any deficits. Fairly common in strokes. Anterior cerebral artery strokes, they are very similar to middle cerebral artery strokes, the big difference being that a person typically has worse weakness in the legs than the arms, which is opposite to the middle cerebral artery. Internal carotid artery strokes, sometimes they present only as transient blindness in the eye on the side of the internal carotid artery which is involved. This happens because the one of the first branches of note of the internal carotid artery is the ophthalmic artery, which goes straight to the retina, and plaque, especially from carotid artery disease, that breaks off, and small particles, they get lodged in the ophthalmic artery, thereby obstructing blood flow to the retina, thereby causing this transient loss of vision. Stroke much more difficult, in my opinion, to latch onto than anterior circulation stroke, oftentimes because they present as simply as sudden nausea or vomiting or dizziness or lightheadedness. The one of the few consistent clues to this being more than a person who is dehydrated, more than a person who has a headache and felt nauseated or sick to the stomach, is worsening of the level of consciousness, changes in the size of the pupils, one side versus the other, and nystagmus, which is this beating movement of the eyes to one side or the other. Those in conjunction with the dizzy spell or the nausea, vomiting, is generally taken as a dangerous sign. Very important slide. These are the differentials that you need to consider when first evaluating a patient with suspected acute stroke. I do not think that any of these differentials or these diagnostic thoughts in the back of your minds should slow down or stop the triage of a stroke patient. The important ones, the common ones that we see are seizures, migraines, and hypoglycemia. Migraine is only going to be apparent by history, and it is strictly a diagnosis of exclusion, by which I mean either you have imaging which was negative when a person was having symptoms, which ruled out a stroke and a bleed. As far as seizures are concerned, they can present with weakness on the side of the body that was seizing, and this weakness can last up to 48 hours. And this is oftentimes, especially if the seizure is not witnessed, confused for ischemic strokes. However, the caveat to this is that a seizure can be the first presenting symptom of a large stroke, and especially a hemorrhagic stroke, a bleeding kind of stroke. So therefore, again, if a seizure is on your list of differentials, it should not slow down the evaluation at all. Hypoglycemia, this is a big one because we can diagnose this in the field, and the symptoms can mimic a stroke perfectly. And if you correct the hypoglycemia, the deficits, the weakness, the loss of language, the change in the level of consciousness, all of those should reverse. And therefore, you have now prevented getting TPA or worse. Um, Basically, just quick bullet points that I coming to the management. So initial triage. The slides are slightly out of order here because the first thing that should have come in should have been the clinical history and the examination. There's several clinical assessment scales of acute stroke. The ones that are done in the hospital, the main one being the NIH, the National Institutes of Health stroke scale, the ones that are done outside in the field. There are numerous ones, the Cincinnati pre-hospital scale being a common one, the LA scale is another one, the stroke vans, VA, N as in Nancy, S as in Sam, that's another one, and the race, R as in rocket, A, C as in comet, E as in electric, score, again, being some of the ones that are used. Most of them have somewhere between a 50 to 60% specificity and sensitivity. The important thing is, again, if there's a clinical suspicion for stroke, and a person does have an exam which is consistent with stroke, they are an acute stroke unless imaging proves otherwise. Um, these are the tests. Again, like I said, glucose is an important one. INR is an extremely important one because you cannot give IVTPA to patients whose INR is more than 1.7. In the CBC, there are a couple of important ones. If a patient has a low platelet count, 50 to 100,000 or lower, they should not be given intravenous TPA because the risk of bleeding goes up. As far as the BMP is concerned, there are no hard and fast contraindications, but if a person is severely hypo or hypernatremic, too high or too low a sodium, they can mimic signs and symptoms of stroke. Cardiac enzymes. The importance here is that if a person's in the middle of a STEMI and you give them TPA, there is a high risk of myocardial rupture and therefore sudden death. Urine drug screen for obvious reasons. We will come to in a second. The first of which is CAT scan. The next couple of slides are going to be illustrative examples of stroke, both bleeding and ischemia. The first slide is two examples of this being a right-sided thalamus acute stroke, acute bleed, sorry. Bleeds in the first 6 to 24 hours on a CAT scan, they appear white. This is a similar bleed which is now on the left frontal lobe. Uh, Larger bleed, as a general rule of thumb, the higher the morbidity and the mortality. Deeper bleeds have higher risks of death and complications than do surface bleeds. This is two CAT scans, both with right-sided strokes, MCS strokes. In this case, it is this dark, homogeneous, amorphous-looking patch of stroke. Same thing on this side. This is a particularly severe example because of the fairly large amount of mass effect. and also hydrocephalus that's developed because of ventricles that have been trapped by the swelling itself. In this, all of the ventricles are open, and therefore there's no mass effect. Um, this now is an MRI of the brain. In the MRI, the coloring scheme is the opposite. The strokes appear white on this sequence of imaging, and its mirror image black on this sequence of imaging. This pattern of imaging is treated as an ischemic stroke with very few exceptions. This is another illustrative example of a person having suffered a middle cerebral artery occlusion. Let me take a quick minute to go over this scheme of vessels. So starting from the bottom, this is the internal carotid artery. This is the middle cerebral artery. This is the anterior cerebral artery. This is the vertebral artery. This is the vertebral. This is the basilar, and this is the posterior cerebral artery. Again, this being the right middle cerebral, the left middle cerebral is absent completely, and because it is absent, this whole right white part of the left hemisphere has suffered permanent infarction. This is a comparison of a few imaging sequences as to how they show blood. This has both subarachnoid and intraventricular hemorrhage, and I will point those out. This is the CAT scan. In the CAT scan, what's basically happened is these gyri, instead of being black, are white now, and white means blood, as we had seen in a few of the previous images. So all of these gyri, they have blood in them, hence the definition of the subarachnoid hemorrhage. This same picture taken, this same patient had an MRI done immediately afterwards, and in the MRI, blood appears black, so you see subarachnoid hemorrhage again, and this is now later on at 22 hours, as it says, in a separate sequence of images. The important thing that I want you to remember in this is compare the size of these ventricles to the size of these ventricles. And what's happened from here to here is because of obstruction of the normal absorption of spinal fluid, all of that spinal fluid has started building up in the ventricles, thereby causing hydrocephalus also, which is one of the feared complications of subarachnoid hemorrhages. Subdural hemorrhage, lens-shaped, white, collecting between the surface of the brain and the inside of the skull, causing a lot of swelling and compression. You don't see any gyri, you see plenty of gyri and sulci on this side. Intraparenchymal hemorrhage, which basically means that the bleed happens within the parenchyma or within the substance of the brain itself. All of these, again, blood appearing dark on MRI and white on CAT scans. Now coming on to the treatment objectives, basically the same as everything else. This first one is become very, very important again since the advent of mechanical thrombectomy, clot retrieval. And I again won't go into any of these things. These are the same as any and all field management. A couple of important things in this slide. For ischemic strokes, blood pressure should be less than 220 and 110. And if they've been given TPA, then 180 by 105. Hemorrhagic stroke, blood pressure should be kept less than 160. This, of course, is only apparent after you have done a head CT. If the CAT scan shows bleed, then 160. If the CAT scan does not show bleed, then less than 220. Sorry. Insulin to treat hyperglycemia, glucose to treat hypoglycemia, early use of Tylenol to lower temperature because both too high or too low glucose and too high temperature, they worsen outcomes in stroke patients. This is what I had meant by the slides being slightly out of order because I had wanted this slide to be at the beginning. This is important. This is the standard teaching message of the American Heart Association, American Stroke Association, and regional stroke associations, Minnesota and South Dakota also. Ischemic stroke, quick blurb about the TPA, standard of care, ever shortening list of contraindications, the dose, bolus infusion. For most patients, the time window is 3 hours. In some certain specific cases, the time window can be extended to 4.5 hours. Hemorrhage has to be ruled out. Hypo and hyperglycemia has to be ruled out. A person shouldn't have active bleeding anywhere. A person shouldn't be on heparin drips, and a person shouldn't have had recent trauma or major surgeries on the gastrointestinal tract, the spinal cord, the brain, and on the urinary tract. Then, after the TPA discussion has been had and a decision made, the mechanical thrombectomy discussion, like I had said, 2015 to 16, large clinical trials came out which supported the use of mechanical thrombectomy in patients. This is not a new technology. We have had devices that were used to do this since 2007, 2008. The problem was twofold. One, we didn't have tools available for careful patient selection, and also the equipment that was available to do these mechanical thrombectomies, these clot retrievals, was not refined, and therefore um, all therefore a lot of complications were had with hemorrhages, which diluted the positive effect of successful recanalization, successful revascularization, up until the 2015-16 winter. Now, one of the very few things in medicine, all of medicine, which has level of evidence 1A behind it. For instance, one of the only other things which has a level 1A evidence behind it is the use of antibiotics for infection. Um, most of the interventions that are done, they never reach this level of interventions. Most of evidence. Most of the interventions, especially the surgical ones, never reach this level of evidence. Now coming to a couple quick patient studies. This is a gentleman who came in just a couple of days ago and had acute onset of left-sided weakness. Again, the weakness was sudden. It was not witnessed, so we couldn't give him TPA. And he also had gaze deviation. He also had severe neglect on the left side. Initial head CT did not show a bleed. CTA was done afterwards, and the important thing is compare that to this. So what's missing is the carotid artery, which is this, and the middle cerebral artery, which is this, and all of its branches. And this is the anterior cerebral artery, which is open. This is the anterior cerebral artery, which is open. This is the perfusion image. What this shows is this side normal, and this color gradation is showing the speed and the volume of blood flow in specific tissues. This red's the highest, and blue is black is the lowest. Blue is just above black. So as you can see, there's large parts of the hemisphere on the right side, which is not getting much, if any, blood flow at all, and that is because this blood vessel is blocked. So then what we did was we took this gentleman to the cath lab, and in the cath lab we saw this. So what we're looking at is an angiogram, a catheter angiogram done through the right common carotid artery. Just to orient ourselves, this is this person's hyoid bone. This is this person's vertebral column. This is the fillings in teeth in the lower jaw, upper jaw, outline of the jaws. And the circle here indicates this severe narrowing at the beginning of the internal carotid artery. This is the common, this is the external, and this is the internal carotid artery. So the first step was we put a balloon in through this part. This is the markers of the balloon, and pulled, once we had the balloon up, pulled it down into this region, and did angioplasty to allow us room to get into this blood vessel. So now finally, after angioplasty, the carotid artery looks like this, and this catheter tip, which is down here, is now all the way up into the carotid artery. Next set of images shows two catheters. These images are taken from the head-on, and what we're seeing here is this is the orbit on the right side, this is the orbit on the left side, these are the bones of the nose, and this is the cheekbone. So same catheter that we saw in the last picture, this is the balloon that's mounted on the catheter. This is the catheter within the catheter, which is going to be navigated all the way out to here. And this is that blocked middle cerebral artery out here. Once we were able to get this here and snare the blood clot, now blood flow has been restored into the middle cerebral artery. Again, this balloon makes sure that if you do break off some of the clot as you're trying to pull back, it doesn't just go up and block some of the other smaller branches, that you can pull the whole thing down. This is a depiction of the types of snares, if you will, that we have available. This is where we started off with. This was the Mercy device. These are the stents, and now all of these different shapes of stents are available. They all do the same basic thing, which is snare the clot, latch onto it, and pull it back down, with a view to restoring blood flow to the blood vessel. Quick blurb about the hemorrhagic stroke, which basically is bleeding out of either an aneurysm or a normal blood vessel, because of trauma or problems with the blood vessel itself. The hypertension, we had said, drop systolic below 160. If there's any coagulation abnormalities, use a reversal agent, be that vitamin K, factor concentrates, fresh frozen plasma. If there's mass effect, then they need to go to the OR immediately for decompression and evacuation of the hematoma, and obviously definitive treatment for aneurysms and vascular malformations. This slide basically shows all of the endovascular ways of treating aneurysms. Aneurysm sac, coils being pushed into the aneurysm, a balloon being used to seal the neck of the aneurysm off, stent being used to seal the neck of the aneurysm off, two stents being used to do the same thing. This is what's called a waffle cone technique, again, not important. This is what's called a flow diversion stent. So what it does is it stops blood from getting into the aneurysm, diverts it away from it. Then this is the newest one that we have, in which you basically deploy this basket inside the belly of the aneurysm, and it again seals off blood flow at the neck of the aneurysm. This is the last and final case. This shows a gentleman who had presented with a seizure at onset, and after that went unconscious. This illustrates why seizures, even if witnessed and seen and confirmed, are not a reason to stand down and slow things down. His seizure was caused by this bleeding in the substance of the brain, so intraparenchymal hemorrhage, subarachnoid hemorrhage, and intraventricular hemorrhage, all types. Then underwent a CTA, which shows this aneurysm at the bifurcation of this middle cerebral artery. This is his angiogram. That's the aneurysm, and that's the aneurysm. The important thing is that in the vicinity of the aneurysm, there's 1, 2, and 3 blood vessels. 1, 2, and 3 blood vessels. So I went into the aneurysm. This is the catheter. These are all of these coils that have been put into the aneurysm. So at this stage, things look awesome because there's no blood flowing into the aneurysm, you still see 1, 2, and 3 blood vessels, still see 1, 2, and 3 blood vessels. However, a little bit later, this big one in the back, this big one out here goes missing because one of these coil loops here and back here that came back down onto the origin of this blood vessels. I tried for a good 30 minutes, 45 minutes to try and move these coils, but was unable to do so. And now what ended up happening was that this CAT scan, which was the first one, turned into this CAT scan. What this shows is the artifact introduced by the coils, a ventricular drain that had been placed to reduce the intracranial pressure, and changes of craniectomy. So this part of the skull's missing, this part of the skull's missing, and this had to be taken off because the irritation and the swelling induced by the blood clot became so much that this person started moving, shifting all of the brain over to the healthy side. In addition to the effect of the blood, this dark patch, which wasn't here before, is the damage caused by blockage of that branch. So this is the stroke caused by the blockage of this branch. Um, with this, I will move on to the last two slides. This is prognosis. These are the important things. Up to about 10%, so 1 in 10 patients will die in the first 30 days from an ischemic stroke. And as far as hemorrhagic strokes, that number goes up to 1 in 2 even with the best medical care. That is the end of this presentation, guys. If there's any questions, those can be emailed to me, and if there's any critiques, I welcome those. But thank you for your attention. And like I said, questions, comments, please feel free to reach me by email.